Okay, and what about my screen? Is
Sir,
it shared?
no, it is not sharing. Screen share is not on,
Okay,
but
okay.
I can see your video
Yes,
clearly.
yeah. Is it shared now?
Yes, sir. Now it is shared.
Okay. So here in this image, in this slide, we have tried to make a panoramic view image of the same structure. And here, uh, a three-dimensional image is also made over here. You can see this is a three-dimensional image of the vessel, but still it's difficult to be recognized. So for that purpose, how could we overcome this limitation of ultrasound? So that could only be possible to improve the operator knowledge, so he could be able to decide on real-time ultrasound image. So the provocative manure and vascular Doppler examination are too common and usually applied to some are great extent in the vascular lab, while other are uncommon and experience based. Here we will discuss a few most common ones. For example, compression, relaxation of the transient distal compression, Valsalva maneuver, distal augmentation, follow-up in short excessive, change protocol are important settings, use arterial calcification as landmark for the evaluation of adjacent veins, and changing the position of patient or structure under examination. So, uh, first of all, we are coming across the compression. So, conventionally, compression was used to detect DV. You can see in the first image, this image has been taken of the right inguinal region. And here you can see this is common femoral vein, and on the lateral side there is common femoral artery. But just the next image, this is a compression image, and during this compression only artery appear, but the femoral vein and great saphenous vein were disappear due to compression. And the other image, here you can see this is common inguinal region. So he joined by a great saphenous vein from the medial side, and laterally there is common femoral artery. And during compression, only the femoral artery appear, but the common femoral vein and great saphenous vein were disappeared due to compression. And the third image you can see this is a color Doppler image, and here you can see the color is over here, but this region is devoid of color and having ecogenic contents inside it, that is due to DVT. Okay, so I'll show you another image of DVT. And during compression, here you can see this is without compression image, and this is a common femoral artery, this great saphenous vein, and here you can see and here the common femoral vein is at the same map represent red color while the upper channel blue color. So by this blue color mean this flow is from deep to superficial, and this flow is from superficial to deep. So this is right, but this is wrong. This is reverse flow. If there is any reverse flow in the perforator, so it's mean the perforator is incompetent. That's why blood flow is coming back in backward in direction. So here you can see in this case, once the region of interest was compressed, so blood flowed from superficial to deep, but whenever it was relaxed, so the flow direction was reversed, and now it is mapped in blue color, which represent towards the transducer. The flow direction is now from deep to superficial. So that could also be evaluated with the help of compression. So some of the compression are used commonly and the vascular labs for the detection of DVT, but it could also be used for other purposes. Just for example, here you can see it's a bit difficult to evaluate posterior and anterior tibial veins or peroneal veins, but that could be achieved with the help of compression. So here you can see this is a posterior tibial artery accompanied by two veins. So with the help of compression, now only artery appear, but the two veins were disappeared. The same way here you can see this is femoral artery, which is accompanied by two veins here and here. So that could be achieved with the help of compression. We can localize with the help of compression as well. So here in this image, you can see this is cephalic vein and this is brachial artery. So that is important for the AV fistula mapping. Arterial what could be happen when there is compression on the arteries. So with the help of if we compress arteries with the transducer too much, so there could be resistive flow and artificial stenosis will appear in the artery. So care must be taken for the structure under examination or for the arteries under examination should not be too compressed, and that is in the more superficial arteries at the distal extremities. Just for example, radial ulnar artery or dorsal spidus artery, which is just beneath the skin. So that could easily be compressed with the help of transducer. Because sometimes while localizing the vessel, talking about arteries, some of arteries are too hard and they could not be compressed, but with the excessive amount of pressure, arteries could also be compressed, and there will be artificial stenosis, characteristic of artificial stenosis in them. Relaxation of the transient distal compression on vein. So whenever veins are whether there is some distal compression occurred distal to the sampling site. So what will happen with the vein? There will be cessation of blood flow, but after relaxing, there will compression. So if there was reversal of flow, it's mean there will be chronic venous insufficiency, venous valve will be incompetent, and that's why blood will flow in the backward direction. So that should not occur during the relaxation, abrupt relaxation of the distal compressed region. Just for example, initially you compress the cough region or anywhere else distal to the sampling site, and that compressed region is suddenly relaxed. And due to that sudden relaxation, if there is reversal of flow in the vein, that will reflect the chronic venous insufficiency, which means the venous valve will be incompetent. At distal arterial relaxation, effect on arteries will be such that, just for example, we compress distal region to the sampling site, and we are mapping artery. So there will be initially a resistive blood flow due to the excessive pressure, and whenever we relax it, so here in this image you can see initially there was resistive blood flow, but whenever it was relaxed, so suddenly there is low resistive high velocity blood flow, that is due to distal relaxation. Then you are commonly used in vascular lab Valsalva maneuver, and that is for the evaluation of chronic venous insufficiency or venous well evaluation. So here, an effort of expiration with closed glottis after de-inspiration to build up intra-abdominal pressure. This maneuver is Valsalva maneuver. So this provocative maneuver is applied most commonly to investigate veins for patency. Patency of the saphenofemoral junction is most commonly interrogated or is most commonly used for the evaluation of saphenofemoral junction. Are you hearing me there?
Yes, sir. I can hear you clearly. Yes, sir.
Okay. So here in the first image, you can see this is a competent saphenofemoral junction. And during Valsalva maneuver, there is no reversal of blood flow at all. And after relaxation of the breath, there was a surge of blood flow. So this is competent. But in the second example here, you can see with inspiration, an effort of forceful expiration, there is reversal of blood flow. And this, if this reversal of blood flow is for more than 0.5 seconds, so that could be accounts for reversal of blood flow or the venous insufficiency or venous well incompetency, you can say. Here again, in the other example, you can see this is normal. Valsalva maneuver here with the inspiration, with the forceful uh, effort of expiration. During that effort, intra-abdominal pressure increases, intra-abdominal IVC collapse, and the reverse, the return of blood flow is ceased. And due to that cessation, here you can see there is no blood flow at all. So this is competent. There is no reversal during that cessation of blood flow. But in the second example here, you can see there is reversal of blood flow during Valsalva maneuver, and this is incompetent saphenofemoral junction. Okay. Then we are going to perform another provocative maneuver, that is distal augmentation. So sometime we are going to augment distal part of the vein, and particularly that is for those vessels where there are no blood flow, veins where there are no blood flow is detected with the help of color power Doppler. And sometimes some patient will come to you while they are bedridden for a long period of time. So there will be very slow flow, and the RBCs will clump with each other. And due to that clumping of RBCs, they will appear echogenic. So here in this example, you can see this is a large vessel, but here you can see the blood inside the vein appear echogenic. That is due to very slow flow. So the RBCs are clumped with each other. They act as a large reflector or scatter. That's why they will appear on ultrasound with low level echoes. But such appearance could also be seen on grayscale ultrasound and DVTs. Then we are going to apply compression. But in acute DVT, the clot will be compressible, and that will be difficult for us to differentiate. That's why we will apply distal augmentation. And by that distal augmentation, we'll be able to differentiate between a clot and a normal vessel. Just for example, we augmented the vein, then with that augmentation, there will be a surge of blood flow return towards the heart. Okay. Then follow the vessel in short axis view. So that is also a provocative measure because we know the course of the vein varies from place to place. Some and at some region it will be too deep, while at the other region it will be superficial. So with the help of a high resolution linear transducer, it will be easy to localize it while it is superficial. So we will localize it at the superficial region, and then we will follow it in short axis view to the area when there it will situated deep. So that and that short axis view, you can say that a left manner. So with the help of a left manner, just for example, you will place your transducer in short axis view over the vessel. Yeah, I have changed my slide. Yeah, opening the pen. So you will place your transducer over here in short axis view, and then you will sweep it up and down. So with this manner, this patient, you can evaluate that vessel or follow that vessel from superficial to deep part. So here at the region of adductor canal, most commonly arteriosclerotic disease will occur at this region, and that is too deep. So that's why you can follow it from the proximal region with the axial view of the transducer, or you can try to localize it inside the adductor muscle. So by localizing these vein and arteries, so here at this adductor, yeah, the thigh region, superficial will be the vein and deep will be the artery. So at this region, you will have to localize it in short axis view, and then you will have to rotate your transducer in long axis view for taking the flow pattern of artery and vein. So that is the method of following any vessel from superficial to deep region. Then sometimes it is important to change the protocol, although that is a bit complicated phenomena, but I'll try to summarize it. You will see IP settings on the machine, that is internal preset settings, and you can say internal preset curves. Because the echoes which are coming from inside the body, they have a great deal of difference between different amplitudes. So that great difference of amplitude could not be handled by the ultrasound machine, and that's why ultrasound machine compress it to decrease the difference between the high amplitude and the low amplitude. And for that purpose, some internal presets have been made by the engineers for particular protocols. And in some presets, low amplitude echo have been given preference, while in the other protocols, high amplitude echoes have been given preference. But in some cases, the mid-range echo are given preference. So here for this purpose, and if we are going to perform examination of arteries, then there will be arteries have been given preference to the high amplitude difference, and veins have been given preference to the low amplitude difference. So here I have given two images for the purpose of comparison. So the first image here you can see arterial protocol are selected, but in the second image you can see venous protocol are selected. So here it is difficult to differentiate the walls of the vessel, and here it is too easy and too clear to differentiate the walls of the vessel, because at this protocol high amplitude difference have been given preference, But here at this level, at venous protocol, low amplitude echoes have been given preference. At the arterial protocol, low dynamic range is used, but the venous protocol, high dynamic range is used to evaluate inside the vessel lumen, the blood flow. Uh, Sometimes it is important to change the protocol settings by machine sensitivity. Okay, so here you can see these are posterior tibial artery as well as posterior tibial veins, but we are able to detect blood flow with the help of color Doppler and even in short axis view that appear artery and these two are veins, but that is due to increase in the sensitivity of the color Doppler. Here you can see the scale, which is set to 5.3 centimeter per second. So any flow, any velocity which is more than 5 point, which is less than 5.3 centimeter per second, that could be detected over here. So that's why due to this high sensitivity, the blood flow in the posterior tibial vein is also being detected. The same when the other image here you can see these two are veins and the central one is artery. Uh, Use of arterial calcification as landmark for the evaluation of adjacent vein. So in some senile age individuals and arteriosclerotic diseases, so most of the arterial wall become calcified, and due to that calcification, sometimes it will give proper shadow. Just for example, here you can see these are calcified arterial wall which appear highly echogenic. So the same way here you can see these are calcified arterial wall. That's why they appear echogenic. And due to that echogenic appearance of the arteries and the distal part of the body, just for example, posterior tibial artery, peroneal artery, anterior tibial artery. This, with the help of that calcification, we'll be able to localize these arteries, and then we'll be able to look for the adjacent veins because every artery will be accompanied by 2 to 7 veins, deep veins. There is a great deal of difference between the anatomy of the veins. So the number of veins varies from 2 to 7 below the V joint. Then here, this is another artery. Here's a large calcification over here, having posterior caustic shed as well. So with the help of that calcification, we can easily differentiate between artery and other structures. Sometime you can change the axis or the approach of our transducer. Just for example, we are going to perform evaluate the peroneal artery. So, and if it is difficult to localize it from the posterior aspect, then we can evaluate it from the anterior aspect as well. Here in this image, you can see this is tibia, this is fibula, this is posterior part, this is anterior part. So if you take exercise approach from the posterior part, so from here, this peroneal artery along with vein will appear at this region. So that's a bit deep, and the overlying gastrocnemius muscle will hide its visualization. So you can take a third axis from the anterior side as well. So you can see it in between the tibia and the fibula, just posterior to the interosseous ligament. So that is peroneal artery along with veins. So you can change the approach for the evaluation of different veins. You can change the position of the patient as well. Just for example, you have a patient. with the complaint of varicose veins. But whenever you started your examination, and all the veins are normal, and you didn't find any varicose vein. So for that purpose, because the patient experienced these varicose veins in standing position, when their blood pool to the distal part and the dependent portion of the body. But whenever you lie down the patient on the examination table, then blood is not pooling at the distal part of the body. So you can if you have the availability of a hydraulic coach, then you can use reverse Trendelenburg position. And if that is not available, then you can evaluate the patient in standing position as well for the evaluation of chronic venous insufficiency and acute stage, because that will be difficult to evaluate in the lie down position. Then excel in the vascular anatomy. That is utmost important for vascular examination. That anyone who is related to vascular examination, first of all, he should know every vessel, its surface anatomy, its relative anatomy, just for example, sectional anatomy, and all the related structure anterior and posterior to it. Then he or she will be able to perform the vascular examination. Otherwise, vascular examination not too easy without anatomy. So it's requested to all the sonologists and all the people who are related to vascular examination to excel in anatomy. So that is also important. I have some of the mm, good images for you, interesting cases. So here you can see this is right femoral vein. But here in this right femoral vein, you have cardiac activities. These are cardiac activities and these are in the vein. So if you get any cardiac activity in the distal veins, that could be pathological, and most probably that pathology will be from the heart. So evaluate that patient for heart as well. And here in this patient, there was tricuspid regurgitation. That's why the cardiac activities were evaluated in the distal part of the femoral vein. The same way, here you can see this is the femoral vein at adductor canal, and here you can see the cardiac activities in the femoral vein. So there must be respiratory physicity, but cardiac activity must not be there in the distal veins. If the peripheral veins having cardiac activities, there may be chronic venous insufficiency, and that chronic venous insufficiency could be caused by right heart failure. So right heart failure is also one of the cause of chronic venous insufficiency. There is another case which has a dichrotic notch and the systole. During systole, the heart was both ventricles were not fully contracted, but once they were contracted, then they were relaxed, and again they were contracted. That's why there was a dichrotic notch. So this type of dichrotic notch is also reflect any heart pathology. So for that purpose, you have to refer the patient to the echocardiography. And, uh, and the last but not the least, be professional. So be professional, sincere to your patient and your profession, for which you have been selected by Allah subhanahu wa ta'ala, although it was not difficult to select others instead of you. And thank you very much for your patience. And if you have any question, you can ask.
Thank you very much, sir. There is a question a student asked. He said that is there is possibility that we can see the 3D structure of the arteries?
Yes, sure. We can see 3D structure of the artery as well, because, as I showed you of the image. And there was a 3D structure of the artery. You can see artery as well as the vein. But in spite of that, as I told you, that the field of view of ultrasound is limited, so that will be limited.
Okay, and there is another question, sir. That is how to differentiate between monophasic and dichrotic notch.
Okay, monophasic blood flow mean if there is no phase at all. Just for example, venous blood flow, this is monophasic blood flow. And dichrotic notch was during cardiac activities, during systole. During systole, there were two forward flows. It's mean the heart ventricles were two time contracted in the same cycle.
Okay, thank you, sir. This is all for today. I am very thankful to you for your precious time. Thank you very much. I
Thank you very
recorded.
much to you, Dr. Rozier, and to the all the team of the Afro-Asian
Sir,
Institute and all the participants.
here's the last question.
Hmm.
Any compression in chronic DVT required? If there's any compression required for chronic DVT?
Any compression
Yes, yes.
for chronic activity, no compression is required because once you have a lot of other criteria as well because DVT is too you can say it should not be compressed to such an extent that sometimes some of the part of that DVT could dislodge and that can cause pulmonary embolism. So for that purpose, you have a lot of other criteria. Just for example, a chronic DVT, you will have ecogenic content inside the vein. There will be no Doppler flow, even on the distal augmentation. So that why will you compress the DVT? Because that can result in serious consequences.
Thank you, sir. And there's another question that can we see normal perforators in ultrasound?
To some extent, we can see normal perforator as well, but too difficult. And with meticulous examination, and normally I think there is no need at all. But once you have to follow the entire superficial venous system as a left pattern, as I already told you that in the short exercise you have to interrogate the entire superficial. Just for example, a great stiffness vein and small stiffness vein. So if there was any large dilated perforator, that will be significant. Otherwise, there is no significance.
Sir, there is another question that is how to solve sluggish flow in veins, especially in standing position.
Okay. In standing position, if there is sluggish flow, very slow flow, that will be difficult to be evaluated with the help of color or power Doppler because that will be too slow flow. So with the help of distal augmentation, we can increase the surge of blood flow and that could be evaluated.
Thank you very much, sir. Thank you for your precious time. I hope our audience enjoys this lecture very much. Thank you very much.
Welcome. Thank you.
A recorded version of this webinar will be uploaded soon in our Facebook page, our YouTube channel. All the links will be given in description. All of the information of our upcoming webinars will be shown are shared in our site. Kindly visit afroasianinstitute.com. Thank you very much. Thank you for your precious time, everyone. Thank you
Thank
very
you.
much.